Queda abierta la mesa para preguntas, comentarios.
Thank you very much, Dr. Haynes. I have a question for you. You have shown very brilliantly that the regurgitic catheter produced thrombi and the PVAC catheter produced thrombi as well. Now we have in the market, or is being introduced in the market, a kind of PVAC catheter with irrigation. Do you think that that irrigation is going to have a significant impact in the amount of possible coagulum that that catheter is going to produce, taking into account that the regurgitic catheter already produced coagulum?
Yeah, I think that the design of a circular catheter is not the issue as much as control is the issue. And I think it's possible, even with an irrigated catheter, to get excess heating and get coagulum formation. And we've seen in clinical studies, even with irrigated RF, a 5 to 10% incidence of the asymptomatic cerebral embolism. So I believe that control, you want to be as aggressive as you can without overshooting the mark. And how do you best achieve that? I think that some of the newer technologies, the pressure sensors that allow you to see what the catheter contact is, the near-field ultrasound imaging that allows you to actually see the growth of the lesion, things that will give us real-time feedback, perhaps in the future, real-time MR imaging to allow us to visualize the lesion formation. That's going to be the important, the best thing to allow us to use the maximum energy to create the clinically effective lesion without excessive heating. But I don't think that there is any one absolute fix for this problem right now. This is we can minimize it, and I think that the changes that PVAC has gone through is going to put it in line with other technologies. But I think that this is something we just need to be aware of and do what we can in terms of good sheath management and aggressive anticoagulation to lessen that risk. I don't know if you guys have any other thought on that.
Dr. Merino.
Yeah, thank you. Very nice talk for all you three. I'm interested because microembolia or thrombus is part of the problem, but the other part of the problem is area embolism. So I wonder, because now the standard is to use regurgitated catheters. That means that we are continuously flushing our catheters, and I am sure that some kind of microbubbles may come from this continuous irrigation. Are you aware, or do you know if it will be possible to implement some kind of filters in our seats, in our catheters? Are they cheap? Are they available? Or what is your impression?
Well, you know, most of the perfusion systems have very sensitive bubble detectors, so theoretically you should not have the possibility of injecting air in through the lumen of a perfused tip catheter. But I'm sure that some air gets in to some patients. One of the things that interests me, though, and this is something that acknowledges that we may never completely eliminate this problem, but maybe we can do a better job protecting patients, are these devices that are being developed in particular for the TAVR procedure patients that deflect emboli away from the arch vessels. There is one device called the Umbrella, which you deploy. It opens up like a fan and actually sends debris past the arch vessels downstream. There's another device that is a cone-like filter that, again, sends embolic debris downstream. And it may be, certainly those are devices that probably should be used in most of the TAVR procedures where they're generating a large amount of embolic material, but it may be that that is something that we will need to consider as well for our AFib patients.
I just wanted to make one comment on that because I also agree that the air is a very big issue, and I think the biggest the sheath become, the most that can really be a problem, and particularly for the PVAC, for the cryoballoon that need very wide sheath. And I know that for the cryoballoon they had a very big deal getting a sheath that was really good enough not to catch air every time that the balloon was introduced. And something that hasn't been mentioned yet is that in these two last studies with the PVAC, which is the very low rates of embolism, they started introducing the PVAC underwater when they put it in the sheath, so that no air was catched by introducing the device. And I think this is in general important, particularly with long procedures where you have to change the catheters, with a cryoballoon procedure where you need two different sizes of the balloon, and you also want to check with a circular catheter in between if you don't have an achieve, and bearing that in mind, it's very important. Since I saw that data, and I saw the data from the transcranial Doppler, because we made 3 or 4 patients live, and we saw that just by introducing or removing the catheter fast instead of doing it slowly, you change the amount of embolism that you could register with the transcranial Doppler. So I started doing it a little bit slowly. It takes 1 more minute.
Dr. Almendral.
So I'm confused about what is the type of material that we are seeing there. Is that air embolism? Is it real thrombus material? Or is it debris? You mentioned, in different articles, people sometimes, they don't define. They say they are lesions, but can we tell by the MRI images what is exactly that is being embolized? Because for us as clinicians, I think that if it is a thrombus embolism, for me it's worse than air embolism, and would be something more difficult to imagine that it will clear away just by itself. So do we know exactly I think that in your preparation, in your experiment, you can tell very well, but in the humans, can we tell by the images?
I think that we don't know. I think that it's all of the above. I think that we certainly know that thromboembolism is an issue because there is data relating level of anticoagulation to occurrence of lesions. So that's at least part of the answer. Air, we know, has the potential for causing these. And in particular, one thing that I don't know the answer to, and I'm planning on looking into this, is that the bubbles that you produce with heating are different than bubbles that you introduce just from sheath introduction. Back in the early days of contrast echo, they would make albumin bubbles by heating because that would denature the albumin, and then they would stay present in the circulation for a long time. And so it's not only the size and number of bubbles, but the duration of how long they stay in the circulation that is important in terms of what kind of injury they cause. So I don't think we know, I know that we don't know the answer to that. I think that clearly the particulate debris is a big problem when it happens, and that's something that we've observed, and that's real. So I think you can approach the particulate issue and the bubble issue by controlling energy delivery as best you can, and the thrombus issue by anticoagulation, but I think we need to do everything because I think they all have some contribution.
I would like to ask a question to Dr. Pagola now, because to me, looking at a little speck on the brain doesn't mean too much. I can read electrocardiograms, but I can't read that very well. Now, from the neurological point of view, are there any other known pictures, diseases, troubles, accidents, whatever, that neurologists may feel resemble this and may give us an outlook of what to expect?
Well, it's sometimes it's pretty hard to weight the lesion that we can find after procedure on the acute MRI, on the DWI imaging. For us, probably is the location of the lesion one of the major points. For instance, you can find a cognitive dementia if the lesion is in the thalamus, for instance. But if the lesion is the subcortical part of the brain, probably the patient remains asymptomatic. But I would like to remark that it's pretty important to examine the patient after the procedure, because sometimes it's the easiest and the cheapest way to find if we have some problems. And it's very, very simple. You don't need a pretty hard examination. It's only a facial weakness, movement on one side or the other side. And because sometimes we will forget this part of the
The problem is that most of the, I don't know, all of the labs, but in many cases we have the patient anesthetized, so you don't know if, he's confused and you don't know if it's an effect of the anesthesia or something's happening. You only check that the patient is moving all the limbs and that's it, but you cannot do more.
Anyway, if you have a little doubt, it's better to call us, better than wait and perform a CT. Or I would like to say something more. Sometimes about the solid microembolism, sometimes you have a higher frequency ultrasound reflection with the solid microembolus. It's higher than the gaseous microembolus, but in the real world, it's pretty hard to differentiate each other. But this is a technique, it's only online multi-frequency Doppler, and you can use it if you are really interested in it. Oh.
Okay, thank you. I wanted to ask just one question to Dr. Herrera. Well, you mentioned that there were two important moments regarding microembolic events, and one was the moment in which we performed the transeptal puncture, and the other one was when we were ablating. But, well, you didn't mention anything about the end of the procedure. I mean, do you check if there's anything related to the reversion of the effect of the heparin? Because in some labs, they do not give protamine or something to antagonize the heparin effect, but we do, and I'm concerned about it, because I don't know if this can be related to some events.
Well, the data that I presented were, of course, just data done during an ablation, and they didn't revert the anticoagulation. They just checked this 10 minutes before and after the procedure, I think just to have a control of what was happening when we were not doing anything actively, what happened spontaneously. So I don't really have the answer, and I also don't know whether these showers on the transcranial Doppler are really the ones that are going to do the lesions in the post-procedural MRI. I think it's something that you cannot really tell. You should stop after the transeptal, do an MRI, and then keep on the ablation to get this answer. But concerning the anticoagulation, the current trend is to keep the anticoagulation as stable as possible. And that's why also the current trend is during the ablation, during ongoing anticoagulation, I've even heard people that advocate against the new anticoagulation drugs on these patients that are planned for an ablation because you cannot ablate under ongoing, it's not advised to ablate under ongoing dabigatran or apixaban. And in our lab, for example, we do not revert the heparin. We send the patients with the sheath to the ward, and then they get ACT controls, and then the sheath are removed when ACT just drops spontaneously. And of course, if you have behind that an already therapeutic INR, then the patient is really covered the whole time.
Yes, one more question.
Considering that the initial mechanism for thrombi is denaturation of proteins, or blood proteins, because of the overheating, and that you start a process of you start the coagulation cascade, but you also have a problem of aggregation of platelets. Do you think that, or any of you think that maybe just fight the platelet activation through anti-aggregation could have any impact on thrombi formation?
That's a really important point, and we just have some small data that seems to indicate using clopidogrel and aspirin pre-procedure may have some protective effect, but we don't do that clinically. I know David Keene does that routinely, but I think most people depend on heparin alone. But that's a very, very important point.
Any other questions?
So now I think we can close if there are no more questions. And thank you very much to all of you. Nice presentations, and I think we are on time. So that's it.